Hello everyone. So today we'll be discussing smoking and periodontal diseases. So we will be seeing introduction, various form of tobacco usage, systemic effect of nicotine, local effects, passive smoking, effect of smoking on prevalence and severity of periodontal disease, effect of smoking on etiology and pathogenesis of periodontal diseases, right? So effect on host. Effect of smoking on it causes effect on smoking on leukocytes, neutrophils, and effect of smoking on antibody production. Then effect of physiology, that is microvasculature of gingiva, and effect of smoking on response to periodontal therapy. Then effect of smoking on surgical treatment, on maintenance therapy, role of dental health professional for smoking, and pharmacotherapy therapy support, and at the end conclusion. So first of all, introduction. Tobacco. Tobacco is derived from the species of plant of genus Nicotina. The major varieties include Nicotina rustica and Nicotina tabacum. Raw and processed tobacco contain more than 2,500 different chemical constituents. Tobacco use is directly related to a variety of medical problems including cancer, low birth weight, pulmonary and cardiovascular diseases. In the past 25 years, awareness has increased about the role of tobacco use in prevalence and severity of periodontal disease and eventual tooth loss. The major constituent of tobacco and their adverse effects are polycyclic aromatic hydrocarbons that causes carcinogenesis. Nicotine is also a carcinogen. Phenol, it is a ganglionic stimulator and tumor promotion. Benzopyrene causes tumor promotion and irritation. Then carbon monoxide, that is impaired oxygen and transport and repair. And nitrosamine causes cancer. Smoking is now recognized as the most important cause of preventable death and disease. Smoking appears to be one of the significant risk factor in development of progression of periodontal disease. Dentistry has long been aware of the effect of tobacco on the soft tissue of the oral cavity and the implication of this in clinical practice. There are various forms of tobacco usage, that is smoking and smokeless. Smoking are manufactured cigarettes, BDs, Ritex, pipes and cigars. And in smokeless form, that is chewing tobacco, dry snuff, dissolvable smokeless tobaccos. Manufactured cigarettes. These are the most commonly consumed tobacco products worldwide. They consist of shredded or reconstituted tobacco processed with hundreds of chemicals and various flavors such as menthol and rolled into a paper wrapped cylinder. Usually tipped with a cellulose acetate filter, they are lit at one end and inhaled through the other. Then comes BDs. This consists of a small amount of crushed tobacco hand wrapped in dried tambourine or tendu leaves tied with string. Despite their small size, BDs tends to deliver more tar and carbon monoxide than manufactured cigarette because users must puff harder to keep them lit. Then Critex. They are clove flavored cigarettes. They may also contain a wide range of exotic flavoring and eugenol, which has an anesthetic effect, allowing for deeper and more harmful smoke inhalation. Then pipes. They are made of slate, clay, and other substances. Tobacco is placed in the bowl and the smoke is inhaled through the stem. In Southeast Asia, clay pipes known as salpa, chilam, and hukli are widely used. Cigar. Cigar are made of fermented tobaccos rolled in tobacco leaf wraps. The long aging and fermentation process produces a high concentration of carcinogenic compound that are released upon combustion. The concentration of toxin and irritant in cigars are higher than in cigarettes. Estimation of daily amount of nicotine obtained from cigarettes. In one cigarette, 3 mg of nicotine is obtained. Smokers get 1 mg from a cigarette smoke leisurely over about 5-minute period. Smokers who smoke deeply and inhales rapidly can get up to 3 mg from a single cigarette. Nicotine is the psychoactive compound and is only found in tobacco. This compound is the primary cause for addiction to tobacco products because it acts as a mild stimulant to the central nervous system. In newer smokers, nicotine can induce nausea and if taken in large dosage, it can be associated with tremors, quick breath and a decrease in production of urine. Once nicotine is absorbed into the lungs, it affects reach the brain within 6 seconds, twice fast as mainline heroin. First, in small dose, it makes the person feel awake and alert. With later doses, it produces a soothing, pleasurable feeling that makes the person want more. However, it is important to note that although it produces a feeling of well-being in habitual users, it releases epinephrine, a hormone which creates psychological stress in the smoker rather than relaxation. Second, people usually become dependent on nicotine to the point that they suffer severe withdrawal symptoms which last for a week or longer. Psychological symptoms include irritability, anxiety, sleep disturbances, nervousness, headache, fatigue, nausea, and a long-term craving for tobacco. Psychological symptoms include changes in body. Physiological symptoms include changes in body temperature, heart rate, muscle tone, and appetite. Because nicotine affects the brain and the central nervous system, it affects the user's mood and temperament. So it affects in three regions, that is cardiovascular diseases, lung diseases, and carcinoma. First, we will see the cardiovascular diseases: elevated blood pressure, high cholesterol level, coronary heart disease, and peripheral arterial occlusive diseases. In lung, it may cause chronic obstructive pulmonary disease, that is COPD, chronic bronchitis, emphysema, obstructive sleep apnea, and idiopathic pneumothorax. And in carcinoma, it causes many kind of cancers, including lung, mouth, esophagus, stomach, kidney, pancreas, prostate, and uterine cervix. Now we'll see the local effect of nicotine. Oral tissue of smokers are exposed to high nicotine concentration that negatively affect local cell population. Gingival curricular fluid nicotine in concentration can be up to nearly 300 times than of plasma concentration in smokers. Vasoconstriction property. It was hypothesized that nicotine impairs gingival blood flow. However, studies examining effect of smoking on gingival blood flow in humans have shown no either change or increased flow as measured by laser Doppler flowmetry. This may be due to smoking-induced elevation in blood pressure, which overcomes any vasoconstriction effect of smoking. Smoking impairs revascularization during soft and hard tissue wound healing. Now, passive smoking. Mainstream smoke. This is smoke directly inhaled by the smoker through a burning cigarette. Exhaled mainstream smoke. This is a smoke breathed out by the smoker. Then the side stream smoke. This is a smoke which drifts from the burning end of a cigarette. Nicotine and some carcinogens from the same amount of burnt tobacco. However, because side stream smoke is mixed with the air before being inhaled, passive smokers don't receive the same concentration of toxic chemicals as active smokers, who draw the tobacco smoke directly into their lungs. Effect on unborn child. Chemicals from tobacco smoke can be absorbed into the bloodstream of a pregnant woman. Nicotine, carbon monoxide, and other chemicals can cross the placenta, affecting unborn child. Babies born to the woman exposed to passive smoking are more likely to have a slightly lower birth rate than they would otherwise. Health effects on infants and children. The effect can be seen are sudden infant death syndrome, small lowering in lung function, higher rates of lower respiratory illness such as bronchitis, pneumonia during their first 18 months of life compared to children of non-smokers. Effect of tobacco smoking on prevalence and severity of periodontal diseases. An association between smoking and ANAG has been shown as early as 1947 by Pinbog. Epidemiological studies and published in 1980s and 1990s shows the association between the smoking and destructive periodontal diseases. Depending on the criteria used to define periodontal disease, smokers are 2.6 to 6 times more likely to exhibit periodontal destruction. Pack year defined as the number of cigarettes or packs smoked per day multiplied by number of years that an individual smoked. The odds ratio for a moderate smoker, that is 15 to 30 packs per year, to have a periodontal disease is 2.77 times than that of a non-smoker and a heavy smoker. who smokes more than 30 packs per year is 4.75 times more likely to have periodontal disease than a non-smoker. Gingivitis. Controlled clinical trials in human models of experimental gingivitis have shown that the development of gingivitis in response to plaque accumulation is reduced in smoker as compared to non-smokers. Cross-sectional studies have consistently demonstrated that smoker presents with less gingival inflammation than a non-smoker. Then periodontitis. As overwhelming body of data points to smoking as a major risk factor for increase the prevalence and severity of periodontal destruction. Pocket depth. Studies in which plaque accumulation was kept to a minimum or adjusted in for both in smoking and non-smoking groups. The smoking group had more sites with deeper pockets and greater attachment loss. This was concluded by Linden and Mule. Furcation involvement. A higher prevalence of furcation involvement among current as compared to never smoker has also been noted. Bone loss. In studies which have expressed alveolar bone height as a percentage of root length, the average bone height in current smoker was 77 to 78% as compared to 83% in never smokers. Smoking is associated with increased level of severity and prevalence of vertical bone loss. Smoking is considered a potential risk factor for vertical periodontal bone loss. Nanis in 2000 uh, he studied his aim was assessment of relationship between smoking and periodontitis. More than 12,000 dental individuals over 18 years were participated. Periodontitis is one or more sites which with clinical attachment loss of 4 mm or greater pockets depth with 4 mm and greater were included. Using such criteria established by the Center of Disease Control and Prevention, current smokers are those who had smoked 100 or more cigarettes over their lifetime and smoked at the time of the interview. Former smokers are who had smoked 100 or more cigarettes in their lifetime but were not currently smoking. And non-smokers are those who had not smoked 100 or more cigarettes in their lifetime. Of the 12,000 individuals studied, 9.2% had periodontitis. Smokers were 4 times more likely to have periodontitis than non-smokers. Former smokers were 1.68 times more likely to have periodontitis than non-smokers. Dose-dependent relationships between cigarettes smoked per day and odds of having periodontitis. 9 or fewer odds for having periodontitis is 2.79. 31 or more 6 times more likely to have periodontitis. With former smokers, the odds declines with the number of years since quitting. This data indicates that approximately 42% of periodontitis cases in US adults population were attributed to current smoking and approximately 11% were attributed to former smoking. Former smokers have less risk of periodontitis than current smokers but more risk than non-smokers. And the risk for periodontitis decreases with increasing number of years since quitting smoking. This suggests that effect of smoking is reversible with cessation. Smoking cessation program should be an integral component of periodontal education and therapy. Smoking and aggressive periodontitis. Smokers with generalized early onset periodontitis has more effect teeth and more attachment loss than uh, generalized early onset periodontitis who did not smoke. By contrast, attachment loss was not affected by smoking in younger patients with uh, LJP. The differential effect may be explained by the fact that the disease process responsible for attachment loss in periodontitis may not be of sufficient length to influence by smoking. Then refractive periodontitis. Tobacco smoking plays a significant role in development of refractive periodontitis, and usually high percentage of refractory patients are smokers, that is more than 90% when compared to the percentage of smokers in population. In refractive periodontitis group, neutrophil phagocytic capacity was significantly impaired compared with the control, suggesting that in smokers neutrophil dysfunction may be considered a cofactor in increased susceptibility to periodontal disease. Now, effect of smoking on etiology and pathogenesis of periodontal disease. The increased prevalence and severity of periodontal destruction associated with smoking suggests that the host bacterial interaction normally seen in chronic periodontitis are altered, resulting in more aggressive periodontal breakdown. This imbalance between bacterial challenge and host response may be caused by change in composition of subgingival plaque. With increase in number and virulence of pathogenic organism, change in host response to bacterial challenge, or combination of both. Now, amount of plaque. Shelham noted a gradient of increasing level of gingival inflammation and inadequate oral cleanliness from non-smokers to heavy smoker. Preber et al. In 1990 also reported that higher plaque index score and gingivitis of greater severity in smokers than in non-smokers. In contrast, McGregor in 1985 found no correlation between smoking and plaque accumulation. Now, type of microbial flora. Studies have failed to show quantitative difference in the rate of plaque accumulation of smokers compared with non-smokers, suggesting that if an alteration in microbial challenge in smoker exists, it results from a qualitative rather than quantitative alteration in plaque. Several studies have explored the possible qualitative changes in subgingival plaque caused by smoking with conflicting and inconclusive results. In study of 142 patients with chronic periodontitis, plaque samples from deep pocket more than 6 mm showed no difference in count of AA, PG and PI. In similar studies of 615 patients using immunoassay, the prevalence of AA, PG and PI and E corrodents were found to be non-significant difference between smokers and non-smokers. In study of 790 subjects with different smoking history, it was found that smokers had a significantly higher level of TF, and that smokers were 2.3 times more likely to harbor TF than non-smokers and former smokers. Many discrepancies between the finding of microbiological studies are due to methodology involved. To overcome of some of these problems, a study carried out by Hafizi and Sokransky in 2001 results showed that in ENFN, SV, PI, PN, PM, TF, PG were more significantly prevalent in current smokers than in non-smokers and former smokers. The increased prevalence was caused by increased colonization of shallow sites with no difference in pocket of 4 mm or greater. Maxilla was more involved than compared to that of mandible. Now, the effect on host response. Effect of host response can cause impairment of normal host response in neutralizing infection, an alteration that results in destruction of surrounding healthy periodontal tissue. The impairment of normal host response in neutralizing infection can cause downregulation of host immune response to bacterial challenge, which may affect on leukocytes, neutrophils, and antibody production. In leukocytes, it may affect on salivary leukocytes and on systemic leukocytes. First, we will see the effect of leukocytes. Effect on leukocytes. Neutrophils obtained from peripheral bloods, oral cavity, or saliva of smokers or exposed in vitro to whole tobacco smoke or nicotine have been shown to demonstrate functional alteration in chemotaxis, phagocytosis, and oxidative burst. Now we'll see the effect on salivary leukocytes. Oral leukocyte function is inhibited. This inhibition may translate into enhanced plaque level. Eschel and Sherrick in 1969 demonstrated that a single cigarette provides enough toxic material to inhibit completely the function of oral salivary leukocyte in situ. They demonstrated effect on both aerobic metabolism and glycolysis by leukocytes. Kenny et al. In 1977 confirmed that this observation by demonstrating suppressed phagocytosis of latex particles by salivary leukocytes of smokers related to non-smokers. In conclusion, tobacco component can impair chemotaxis and phagocytosis of oral leukocytes. Smoking impairs oxidative burst of neutrophils. In vitro nicotine exposure inhibits neutrophil production of superoxide anion and hydrogen peroxide, which are important to antimicrobial function. Now the effect on systemic leukocytes. Kral and Kenny in 1979 reported that no difference in chemotaxis of peripheral blood neutrophils from smokers and non-smokers. However, Nobel and Perry reported that smokers have higher blood leukocytes counts. Although bactericidal activity of whole blood did not differ between group, chemotaxis by leukocyte from smokers was suppressed. Neutrophil and response to different level of exposure. Neutrophils are primary mediators of protection against periodontal plaque bacteria. Tobacco smoke exposure increased the number of neutrophils found in systemic circulation. Despite inducing a significant systemic neutrophil, tobacco smoke does not seem to affect the number of neutrophils entering the gingival sulcus and oral cavity. Indeed, limited evidence suggests that the number of neutrophils reaching the gingival sulcus in smokers may be reduced. These findings imply that neutrophil immigration across the periodontal microvasculature is impeded in tobacco smokers. Now, effect on antibody production. Production of antibody are essential for phagocytosis and killing of bacteria, especially immunoglobulin G2 level to periodontal pathogen has been found to be reduced in smokers with periodontitis. Decreased level of salivary IgA, IgG to PI and FN have been documented in smokers. In early onset periodontitis, Quinn et al. Found that IgG to be the only subclass affected by smoking. This explains how smoking aggravates periodontitis by impairing antibody-dependent phagocytosis by neutrophils. Impaired Ig2 response has been hypothesized to increase risk of periodontitis, but a cause and effect relationship has yet to be established. T lymphocyte subsets ratio may be altered in cigarette smokers, leading to decreased T helper cell function, which would compromise antibody production. Alteration that results in destruction of surrounding periodontal tissue. Tobacco components may modify the production of cytokine or inflammatory mediators or periodontal tissue destruction. It elevates TNF alpha, PGE2, neutrophil elastase, MMP8 have been reported in GCF of smokers. In studies of early onset periodontitis, smokers exhibit elevated level of several inflammatory cytokines, including interleukin B, 1 beta, interleukin 6, 8, when compared with non-smokers. In study on the enzyme activity following surgery, the level of MMP8 were relatively higher in smokers when compared with non-smokers, while the level of enzyme inhibitors alpha-1 antitrypsin and alpha-2 macroglobulin were relatively lower in smokers. Nicotine has been shown to increase release of interleukin-6 by culture murine osteoblast. Now, effect on physiology. The clinical signs and inflammation may be due to alteration in inflammatory response in smokers from alteration in vascular response of gingival tissue. Then first we'll see microvasculatures of gingiva. Vascular density. There is no significant difference in vascular density of healthy gingiva between smokers and non-smokers, but the response of microcirculation to plaque accumulation appears to be altered in smokers. Effect on blood flow. Infusion of nicotine results in transient decrease in blood flow. During smoking, there is an immediate but transient increase in blood flow. These results were confirmed by Mekin et al. In 2000. Increased gingival blood flow in occasional smokers and no change in flow in regular smokers demonstrating tolerance. With developing inflammation, increase in GCF flow, bleeding on probing, gingival blood vessels were less in smokers than non-smokers. Smoking and bleeding on probing. Studies have shown that smokers with periodontal disease have less clinical inflammation and gingival bleeding as compared to non-smokers. Smoking suppresses gingival inflammatory response. It exerts a strong chronic dose dependent suppressive effect. Nair et al. In 2003 showed that despite a significant decrease in plaque scores, subjects had a two-fold increase in bleeding or probing after quitting smoking. In addition, oxygen concentration in healthy gingival tissue causes low in smokers. Subgingival temperature were low in smokers, and recovery from vasoconstriction caused by local anesthetic administration take longer time in smokers. Now, effect of smoking on response to periodontal therapy. Healing. Smoking delays healing and impairs the quality of repair after periodontal therapy. Non-surgical therapy. The majority of studies involve non-surgical therapy have shown less probing depth reduction and less attachment gain in smoker as compared to non-smoker. In a study with untreated advanced periodontal patients, scaling and root planing with oral hygiene resulted in significantly greater average reduction in pocket depth and bleeding on probing in non-smokers when evaluated 6 months after completion of therapy. Average pocket reduction of 2.5 mm for non-smokers and 1.9 mm for smokers were observed in pocket that averaged 7 mm before treatment, even though plaque score was less than favorable. When a higher level of plaque control can be achieved as a part of non-surgical care, the difference in resolution of 4 mm to 6 mm pockets between smokers and non-smokers become clinically less significant. The tetracycline family of antibiotics may neutralize substances of inflammation that are particularly elevated in tobacco-associated periodontal disease. Tobacco smoke can stimulate the release of proteolytic enzymes such as MMP, interleukin 1, product of oxidative burst leading to enhanced periodontal destruction. The tetracycline antibiotic gives either in low dose systemically or in higher dose in a controlled local delivery system can counteract the release and activity of these potentially destructive substances. In a study of patients with advanced periodontitis and a relative higher prevalence of smokers, there was marked added benefit of systemic low-dose doxycycline combined with scaling and root planing when compared with scaling and root planing. When scaling and root planing are used in combination with topical subgingivally placed tetracycline fibers, minocycline gel or metronidazole gel, smokers continue to show less pocket reduction than non-smokers. Conclusion to non-surgical therapy. Smokers respond less well to non-surgical therapy than non-smokers. However, with the excellent plaque control, this difference can be minimized. When comparing current smokers with former and non-smokers, the former and non-smokers responded equally when to non-surgical care, reinforcing the need for informing patient of benefits of smoking cessation. Surgical treatment. Among the patients who have been surgically treated for periodontitis and their longitudinally followed as compared to non-smokers, smoker exhibited less reduction in probing depth, less gain in clinical attachment levels, and less gain in bone height. Study done by Scavia et al. In 2001 on open flap debridement without regenerative procedures. The results were by 6 months, smokers showed significant less reduction of deep pockets and non-smokers with less than 3 mm for smokers versus 4 mm for non-smokers and significantly less gain in clinical attachment level even though patient received uh, surgical periodontal therapy even every month for 6 months. Only 16% of deep pocketed smokers returned to 3 mm or less at 6 months after surgery, whereas 47% of deep pockets in non-smokers were 3 mm or less after completion of therapy. Longitudinal study on level of cigarette smoking and response to periodontal therapy. 4 different treatment modalities including coronal scaling, root planing, modified Widman flap surgery and osteoresective surgery were compared. Smokers consistently showed less pocket reduction and less gain in clinical attachment level than non-smoker or former smokers. The difference between immediate and after the completion of therapy and continued throughout 7 years of SPT. During the 7 years, deterioration of furcation areas were greater in heavy and light smokers than in former or non-smokers. Now, root coverage procedures. Root coverage procedures following free thick gingival graft procedure is diminished by heavy cigarette smoking. There are conflicting reports of effect of smoking on subepithelial connective tissue graft. Dennis et al. In 2008 evaluated the effect of smoking on a long-term basis on the stability of gingival tissue following CTG treatment of gingival recession. Results were at 24 months post-operatively, smoking presented poorer outcome with regards to probing depth, gingival recession, and clinical attachment loss. In addition, a more satisfactory stabilization of gingival tissue was found in the non-smoker group. Besek and Cowell et al. Besek Cowell in 2014 evaluated possible effect of smoking on the following: biochemical content in gingival clavicular fluid, samples from sites of gingival recession and saliva, clinical outcome of coronal advanced flap for root coverage. The results were all biochemical parameters were similar apart from salivary nicotine concentration between smokers and non-smoker group. Comparably, high success rates of root coverage with clinical coronally advanced flap in systemically and periodontally healthy smokers versus non-smokers suggest lack of adverse effect of smoking on clinical outcomes. Regenerative procedures. Clinical attachment gain is also less in smokers as compared to non-smokers after regenerative procedures. Smoking has a negative effect on outcome of GTR. By 12 months after GTR therapy for deep intrabony defects, smokers gain less than half as much clinical attachment as non-smokers. In another study, 73 smokers showed less gain in clinical attachment, more gingival recession, and less gain in bone fill of depth. Also, the GTR membrane were exposed in all smokers and approx half the non-smokers. After the use of DFDBA for treatment of intrabony defect, smokers showed less percentage of reduction in pre-surgical pocket depth than non-smokers. Mustafa Balzun et al. In 2004 investigated the association between smoking and the prevalence and severity of vertical bone defects. They concluded that smoking is associated with increased level of prevalence as well as severity of vertical bone loss. And effect of smoking on implant therapy. Implant success rate are reduced in smokers. Overall implant success rates up to 6 years among current smokers were approximately 89 as compared to 95% in non-smokers. But some other retrospective data did not identify smoking as a variable association with implant failure. Moderate to heavy smoking has been documented to result in higher rates of early implant failure and adverse affect the long-term prognosis of implant restoration. Smoking is a known risk factor for osteoporosis and thus may adversely affect the implant success rate through its effects on bone metabolism. Patient who quit smoking 1 week before surgery and abstain for 8 weeks after surgical placement of implant had only one-third as many failures compared to those individuals who continued to smoke. A 15-year longitudinal study has shown that marginal bone loss was greater around implant-supported mandibular fixed prosthesis in current smokers as compared to former or never smokers. In conclusion, smoking has a negative effect on outcome of implant therapy. Since numerous factors can influence implant success, further clinical studies are needed to assess the role of smoking as an independent variable in implant failure. Now the maintenance therapy. The detrimental effect of smoking on treatment outcome appears to be long-lasting and independent of the frequency of maintenance therapy. Effect of smoking on subgingival plaque, host response, and healing characteristics of periodontal tissue may have a long-term effect on pocket resolution in smokers treated with conventional therapy. More studies are needed to examine the effect of antimicrobial and host modulating agents in an attempt to control periodontal disease in smokers. A possible explanation for diminished response to therapy in smokers could be due to difference in pathogen reduction. Some studies shows that there is no significant difference in elimination of pathogen following non-surgical therapy in current smokers and never smokers. However, other studies indicate that certain bacteria were more difficult to eradicate among current smokers. This includes AA, PG, and BF. Role of dental health professionals. General public are aware of the detrimental effect of smoking on general health, but their knowledge of profound effect on tobacco can have on mouth is less well developed. Tobacco control is a term used to describe a broad spectrum of strategies designed to deal with tobacco use, of which smoking cessation is one small part. Advertising restrictions, controlling cigarette price through taxation, health warning on packets of cigarettes, and raising the age of the purchase of tobacco are all examples of elements that compromise the tobacco control agenda. In both primary and secondary care, dental professional can play an helping their patients to quit the tobacco habits. Smoking is a health related behavior that is not easily amenable to change, as nicotine is an addictive substance. Heavy smokers are often users of alcohol, and both habits are known to increase with advancing age. In a survey of general dentists, 65% claims to advise most or all of their patients who smoke to quit, but few provide cessation counseling. Many barriers had been cited by both dentists and hygienists. That is, lack of training and confidence, limited resource regarding funding and materials, and doubts about their effectiveness. Systemic review by Cochrane are considered to be the highest form of evidence. The review concluded that there was insufficient evidence to make a recommendation about the effectiveness of tobacco cessation intervention in a dental setting for cigarette smoking. There are a number of approaches that can be used to give individual advice to smokers. Very brief advices are: the aim of this advice was to draw attention to the smoker's habits, and advice to quit is given that lasts no more than 3 minutes. The main effect of this advice would be to motivate attempt at quitting rather than to increase cessation rate. Brief advice. Brief advices for the patient to stop smoking may last for around 10 minutes. For a 5 steps program for dental office recommended by agency from healthcare research qualities are: ask your patient, advise your patient, assess your patient, assist, and arrange for follow-up of your patient. The emphasis is to offer information, encouragement, and support to the patient, to provide information about resources that may help the patient to become tobacco free. Now, ABC model of tobacco cessation, smoking cessation. A new simple model ABC has recently been integrated into the New Zealand smoking cessation guideline and has been suggested for use by clinicians. A stand for to ask about smoking status. B is to give brief advice to stop smoking to all smokers. And C is to provide evidence-based cessation support for those who wish to stop smoking. Then pharmacotherapy support, that is the use of pharmacotherapy in tobacco cessation began in 1980s. First line therapy is nicotine replacement. Nicotine patches, chewing gums, lozenges, nicotine nasal spray, inhalers are used. Then sustained release bupropion. Then the second line pharmacotherapies are clonidine and nortriptyline. They have more side effects and are not approved by FDA. Nicotine replacement therapy. Selection of type of nicotine replacement should be individualized based on patient smoking habits and preferences. Pack that is 20 cigarettes or less a day, nicotine patch is given. More than 20 cigarettes a day, combination therapy, that is nicotine replacement products are given. Combination therapy. Passive nicotine delivery, example transdermal patch with another medication that permits acute nicotine delivery, example gum, nasal spray or inhalers. Combining the nicotine patch, which may prevent the appearance of several withdrawal with acute dosing form, may provide an excellent treatment option for either therapy alone. Nicotine replacement should probably not considered for individuals who have not previously tried to quit, who use only small amount of tobacco, or an occasional users who have tried to quit and do not have significant withdrawal symptoms, who do not receive behavioral support from clinic staff. Nicotine patch. Nicotine patch comes in a several different dosage ranging from 7 to 22 milligram. After the patient has been smoke free for at least 4 weeks or longer, tapering to lesser strength patch at 2 week intervals has been recommended. So this is how the image shown here. First, a small, bigger nicotine patch is given. Then in next few weeks, quite smaller, and in last few weeks, the smallest nicotine patch is given. Then nicotine lozenges. These are also available in 2 milligram and 4 milligram formulation. Nicotine formed the lozenge is absorbed slowly through the buccal mucosa. The lozenge should not be chewed. The amount of nicotine absorbed per lozenge is somewhat higher than that delivered by gum. Nicotine nasal spray. It delivers nicotine more rapidly other than other nicotine therapy and delivers acute craving relief. The multi-dose bottles with a pump deliver zero point 0.5 milligram of nicotine per 50 microliter squid. Each dose consists of two squids, one to each nostril. The dose of nasal spray should be individualized for each patient based on the patient's level of nicotine dependence. Most patients are started with 1 or 2 doses per hour, which may be increased up to maximum of 40 doses per day. Nicotine inhalers. The inhalers consist of a mouthpiece and a plastic cartridge containing nicotine. When the inhaler is puffed, nicotine is drawn into the mouth of the smokers. Each inhaler cartridge contains 10 milligram nicotine, of which 4 milligram can be delivered and 2 milligrams are absorbed. Nicotine is not delivered to the bronchi or lungs, but rather it is deposited and absorbed in the mouth like nicotine gums. Most people uses between 6 and 16 cartridges a day. The recommended duration for treatment is 3 months, after which the patient may be weaned by gradual reduction over the following 6 to 12 months. Then sublingual tablets. The product is designed to held under the tongue where the nicotine in the tablet is absorbed sublingually. The level of nicotine obtained by the use of 2 milligram tablets and 2 milligram nicotine gums are similar. It is recommended that use the product for at least 12 weeks. After that, the number of tablets used is gradually tapered. Sustained release that is Bupreon Zivan is a newer medication on the market which with respect to smoking cessation and those not containing nicotine. It works by acting on chemical in the brain involved in nicotine addiction and withdrawal. Dosage are 150 milligram every morning for 3 days, then 150 milligram twice a daily. Duration is 7 to 12 weeks, maintenance up to 6 months. Maximum dose is 300 milligram per day, given as 150 milligram BD. Side effects are risk of seizures, dry mouth and insomnia, and skin rash. Then Vernically Clean or Champix or by Pfizer company. It is the newest drug. It is thought to work by reducing the strength of the smoker's urge to smoke and by relieving craving and withdrawal symptoms. The adverse effects are nausea, contraindicated in severe renal impairment, pregnant women and feeding mothers. In conclusion, substantial evidence supports the concept that tobacco smoking has a profound negative effect on periodontal disease severity, prevalence, and incidence and progression. It has a negative effect on all forms of periodontal therapy, leading to less favorable treatment outcomes. 3 to 5 minutes of sedation assistance integrated into clinical service is a potentially life-saving service that benefits patients, community, and practice. Periodontal health and prognosis for periodontal therapy substantially improves when patient quit smoking. So these were the references. Thank you.